Hi, everybody. Welcome to the Q&A session for our Closer Than Ever Chromosome 18 conference. I have three of our speakers here. Two more may join or may not join if they're caught up in clinic right now. We'll see. Or they're even more technically challenged than I am, which I think is also true of them. And so let's have some quick introductions first. If you just say your name and what your talk was about, and then I'll start with the questions that were already submitted. Dr. Hale?
Yes, I'm Dan Hale. I'm a pediatric endocrinologist, and my talk was basically Pediatric Endocrinology 101. So just sort of the basics of pediatric endocrinology.
Okay. Dr. Manganello?
Hi, everyone. I'm Jen Manganello. I am a mom of a child with 18q deletion, and I'm also a public health professor. And my talk was called Health Literacy. And if you're not sure what that is, the focus of what I talked about was on tips on how to interact with healthcare providers and also how to access and use information that you find online.
Okay, thank you. Dr. Larson?
Hi, I'm Cody Larson, and I'm a child, adolescent, and young adult psychiatrist. And this year I talked about obsessive compulsive disorder.
All right, thank you. So we have some questions that have already been submitted. I'm going to try to monitor the chat with questions. So please try to keep the chat to the questions so they don't just get all into the stratosphere before we get to them. So I'm going to start here with Dr. Hale. First question was, what are some things to ask our endocrinologist concerning bone density issues and what therapies we should look into?
So generally, if the child has had fractures, it's obviously a question to raise. Secondly, it's worthwhile to ask about measuring vitamin D, since many special needs children do not spend much time out in the sun, and they often have somewhat picky diets, so they may be vitamin D deficient. Vitamin D is widely available, easily administered, and is probably the most important thing one can do to protect bones in children. So generally the emphasis in terms of bone health is to be sure that children are getting in adequate vitamin D, adequate amounts of calcium, and those are sort of the critical factors. There certainly are medications to deal with bone mineral loss, but that would be something that typically is not a problem in younger children.
Okay, thank you. Dr. Manganello, what different perspective do you think you have being a doctor and a parent of a chromosome 18 child?
That's such a good question, and it's actually something I've been thinking a lot lately. I've actually been hesitant to share my status as a parent of a child with disabilities in my professional world for a variety of reasons. And during the pandemic, I decided to write an article that addressed my experience in a dual role for a journal. And I found it to be a really good experience. And I actually found the reception of that work to be really strong. So I'm starting to try to get a little more comfortable and getting into that role of those two worlds. And so I really appreciate this question. So I think for me, it's interesting because before I had kids, I got my public health doctorate, and my work has focused on health communication. So how do we communicate health information to people in a way that's accessible and easy to understand, and also health literacy? So how do we make the healthcare system easier to navigate? And then I had my son, and all of a sudden I was in this world of having to do a lot of health system navigation, going to specialists, doctors, all kinds of terminology I had never learned before, including the genetics pieces. And it was a real struggle for me at first. I mean, I was overwhelmed as a new mom, and also trying to learn the ins and outs of what will my insurance cover if I travel to Boston? I currently live in upstate New York. So, how does that all work? And what I realized over time is that, as someone with a PhD in public health who actually studies this, I'm still having trouble doing some of the navigation. And so it really opened my eyes as to what a patient experience is really like and where we can make improvements in the system. And I think that that's a perspective that a lot of other people who aren't in my position don't have. So they're doing great work. They're doing great research. They have great ideas, but they don't have that personal experience. And ironically, a year and a half ago, my husband was diagnosed with a very rare cancer, and that put me into that role again. And I just felt so much more prepared. I knew how to make the calls, how to talk to the insurance, because I'd been doing it already for 12 years with my son. So I think it has given me a really unique perspective as someone who studies this and talks about it because of my experience with my son. And I'm hoping to try to merge those two worlds more as I go forward and get more comfortable with that. So thank you for asking me to talk about that.
Good, thank you. Okay, Dr. Larson, could you discuss regression? A parent mentioned that her child's phobias have become worse over time, and things she used to do, she will no longer do.
Yeah, so regression, it's kind of a complicated term, and we usually think of it as sort of milestones that have been met and are no longer that they're no longer able to meet. They're treated worse over time. That's just sort of the natural history of anxiety disorders and phobias. And they tend to, over the course of the lifetime, they tend to kind of wax and wane. And so they often get worse when a child is under stress. And so if there's, something going on, like the school year is about to start, or, we're going through a pandemic, or there's a divorce or something like that, we can see worsening of symptoms or symptoms returning that used to not be there or well controlled previously. And so it's hard to say specifically without knowing kind of the background on that question. But, I think that if there has been, we've all been going through a pretty, stressful year. And so if this is a child who previously had their phobias well controlled and now they're getting worse, we can understand why that might be happening, that this may have been an environmental trigger that is worsening the phobias that were previously controlled. And, sometimes when OCD, anxiety, or most anxiety disorders are sort of in remission, they're pretty well controlled, and then they can start to worsen often when there's an environmental trigger. And that's when it's time to say, okay, let's go back to therapy. Let's get back on our meds if we were on meds, and start taking steps for treating the illness when it's active, as opposed to much less that we normally need to do when the symptoms.
Oops, every once in a while you're cutting out.
In remission.
Oops, I can't tell if you're done. So I know you're on Wi-Fi, so.
The joys of technology.
Oh, no.
Yeah.
I'm on a hotspot. This is on my phone, so.
Oh, okay. I guess I should have known that.
Yeah.
Okay. There's a question for me here, so I guess I better address those two. Okay. The first one was, is there a way to dose CRISPR therapy delivery, especially for duplications? Is there research on that? CRISPR is not ready for prime time yet. There are so many off-target consequences of using CRISPR. If you're trying to make a change using CRISPR with cells in a dish, you have thousands of cells in a dish. You employ the CRISPR technology on that, and then you screen for the outcome you want, and you throw away all the rest. Well, you can't do that in a person. And so it's just a very, very long way away from the reliability one would need to use it as a reliable therapy. And also CRISPR affects one cell at a time. So if you're making a change in an embryo in a dish, or fertilized egg in a dish, and then it grows and affects then the whole organism, how do you do that in a person? It depends on the organ that you think you want to affect. So there are some major hurdles before we're ready to actually think about that as a delivery mechanism. I'm not going to say it's out of the realm of possibility, because who'd have thought CRISPR was possible 10 years ago? So we're not anywhere near that yet. Okay, so I will, move on to, where was I? Dr. Hale. How do I find out if my daughter has a hormone deficiency?
So just generally, you probably start with your GP, and you take in the management guidelines and say, in essence, we know that my child is increased risk of a number of hormone deficiencies, and is this something you feel competent to evaluate, or would you prefer to refer us to a endocrinologist to do the appropriate investigation?
That's a good way to put it. It's positive, but gets to the
and
point.
that child, the pediatrician should be able to look at growth, should be able to order a thyroid test, should be able, if it's somebody of pubertal age, to determine if they're going through puberty appropriately. But beyond that, they probably need to get referred to a pediatric endocrinologist. And given the relatively high prevalence of endocrine disorders in kids with all the chromosome 18 disorders, is fully justified.
Yeah. All right. Thank you. Dr. Manganello, let's see. What is the biggest mistake that families make when navigating healthcare, and in particular, digital technology?
So I don't know that it's so much mistakes, but I think that one of the things that I really emphasize to people is to ask questions. And I know it can be very intimidating, especially when you're going to a lot of new doctors, and there's doctors with all these different specialties, and there's a lot of terms you may not be familiar with. But asking questions is great, and kind of even writing your questions down before you go in so that you have some questions prepared. I know sometimes when I'm sitting in that office and getting some new information, I might get a little flustered. So if I've got my questions ready to go, and then I take some notes as the doctors will tell me the information, that can be really helpful. So it's just, I think some people are taught, or they think it's disrespectful to ask questions, or they feel embarrassed to ask questions, but it's so much better for you and your children if you can get the information that you need and walk out of that appointment being very clear about what you were told, and also what do you need to do next. And so that's one of the key things, is to always say, when should I come back for my follow-up? How often do you think you should see my child? I have each of my son's specialists have kind of a different follow-up schedule. So I'm never quite sure, is this the 1 year or the 3 month or whatever? So I'll just double check that. So I think asking questions is the key thing. And I think when it comes to digital technology, just really being sure that, if you're using, for instance, phone apps to track medication, is that a reliable app? What are they doing with your private personal information, really looking at their privacy policies? A lot of that can be really overwhelming. And frankly, a lot of the apps that we might use for health management haven't really been evaluated to see, do they work, or, are they beneficial? So I think some of that is really just experimentation. Can you find some kinds of technology that will help you? And if yes, just double checking to make sure it's from a reliable company, and they're not just dumping your data out into the world, which can be tricky, but you can usually find that information and look at the reviews and things like that to help you out.
Can I butt in one quick second? Which is, I would agree with what Dr. Manganello said. One of the comment I would make is, it really helps to be respectful of the provider's time. So if you have an hour's worth of questions, and you have a 20-minute appointment, simply say, I have a lot more questions. I understand you have patients waiting. Could I schedule another time to spend 30 minutes or an hour with you? And most of us are able to build that into our schedule. What makes us really anxious and makes us abrupt is when we know there are 3 patients waiting to get into the room that we need to see. But if somebody says, hey, I'd really love to talk a bit more, it's like, well, let's schedule a phone call, for example.
That's a great suggestion. Thanks for adding that.
Or when your hand is on the doorknob because you think the appointment's over, and then the list comes out of 50 questions.
Right.
I try to walk in with my notebook so they know, oh, here she is with all her questions. Like, let's get this figured out.
Yeah.
But yeah, you're right. It is true. You do want to be respectful of the provider and their time. So that's great. Thanks.
Mm-hmm. And just to let you know, Dr. Larson was having connectivity problems, so she went from her office, which is a separate little building where she's on Wi-Fi, into the house. So hopefully her connection will be better in there. So she'll probably be in the closet or something, trying to hide from the chaos in the house. So let's see, where are we? Let's see, I had more questions here. This one's for me. Is there any new info regarding bone density issues for tetras? I'm not sure what new means. New since I talked about it yesterday. No, just that from what little feedback we're getting from families, the calcium and vitamin D supplementation seems to be working. But please, if you're doing that, let us know. When you have a follow-up DEXA scan, let us know whether it helps or doesn't help. We want to know. So we want to get that information out to people, but we haven't been hearing back from too many. So it looks promising, which is great. When a standard therapy is all you really need and it's so simple, this is perfect. This is one of the reasons we exist, because we know such things are going to be out there if we just knew about them. So please help us get that information for all the people enrolled in this study. Let's see, Dr. Hale, could you speak to the benefits and risks of growth hormone therapy and if it helps with general developmental delays?
Well, I mean, the obvious proven benefit across numerous conditions is that, of course, it helps growth, it helps muscle tone, it helps wound healing. So it clearly has some clearly demonstrated benefits. In terms of development, and I'm always very cautious to say this, the only place where we've clearly proven that growth hormone has significant neurocognitive benefit is in children with 18q deletion, not missing the TCF4, not in the children that have the TCF4 deletion, who are growth hormone deficient and treated with growth hormone. There certainly is data in other genetic conditions showing that growth hormone has benefits in terms of neurodevelopmental outcomes. So the 18q data is not outside of the range of what has been seen in some other genetic conditions. But in terms of proving effects, we're limited to only one set of children, which are the kids with 18q.
Okay. Let's see. Waiting for Dr. Larson to get reconnected here. So let's see. I keep seeing questions for her. Here's one for Dr. Hale. Oh, can we connect outside the conference? That question was mine. About Hardy's had 3 fractures in 24 months. Wow. Ortho says bones are really soft and small, despite normal vitamin D levels and normal DEXA scans.
So the answer is they need to see an endocrinologist. More than, for most places, more than 2 fractures in 12 months, or any fractures of spine in children that have issues, certainly is consideration for using some of the so-called bisphosphonates. But that's something that's well beyond the sort of lay public, but something that a endocrinologist or pediatric endocrinologist would be comfortable talking about, and talking about the indications of the risk.
So would you advise a pediatric endocrinologist? Are they going to be knowledgeable about bone density things?
So your community, if you're talking about a private practice pediatric endocrinologist in a small town, probably not. But at any of the large academic children's hospitals, the answer is absolutely yes. We see lots of disabled children. We see lots of children that are long-term survivors of things like childhood cancer, which have adverse impact on bone, children that have cystic fibrosis, children that are on a variety of anti-seizure medications. And so virtually all academic medical centers, the pediatric endocrinologist, there will be somebody that will be familiar.
Okay. I see Dr. Larson, you're back. Do you see us? Okay.
I can see you.
There's a question here for you, but I'm going to kind of take it, and you can add maybe. It says, Dr. Larson, what's the best way to explain your child's syndrome to their siblings? My son is 3, and he just knows his sister has a lot of appointments to teach her things. And actually, I did a YouTube year or so ago about that. But I don't know, Kat, have you seen, you might not have even seen that.
I don't think I have, but we have touched on this a couple times in the sibling talks that, there's never just one conversation, that it's an ongoing conversation that's going to evolve and give more and more detail over time. And, I think they said their child was 3. So, at that time when kids are really young, they're just very concrete. So they're going to want to know, why are they going to appointments? They're going to want to know, what are the things that affect them? And, as they get older, they're going to start to wonder, how did this happen? Is this going to happen to me? Will this, and then when they're even older, they're going to start wondering genetic things, can I pass this on? Am I at risk for this? Eventually they'll start wondering about, what's the future going to be? And so keeping an open communication with them, connecting them with other siblings, and just keeping the dialogue open and being honest with them and keeping it very developmentally appropriate. And especially when they're young, kind of answering what questions they're asking and not giving too much information or really giving them more than they're ready to hear, because you don't fully understand how simple their question is.
Yeah, but they have questions very young, but they don't need to know about chromosomes really young.
Yeah. And that was one of the things that we found in our sibling study, was that the questions really start before they start asking. And so that was one of the pieces of advice, was that, you don't necessarily have to wait for them to ask questions, but be answering and being proactive and explaining why things are different for their sibling, and teaching them before they necessarily start answering questions or asking questions, because they do start to wonder.
Yeah, I remember one comment on the survey was that a sibling their older sibling had a chromosome 18 condition. And so they thought when they got to that same age, they would be that same way. They didn't understand that there was a fundamental difference between the two of them. So right. The questions the siblings come up with are things that, as a parent, it just would not even occur to you, really.
Right. Yeah, is it contagious? Things like that they might, they might wonder about.
Mm-hmm. Although, if I can put a plug in for your survey, to me, the most amazing comment that came out of that was that the siblings felt angry at people who assumed that their special needs sibling was a burden on the family. And that so many of the siblings that never even really occurred to them, it sounded like. And that they wanted to defend their special needs sibling, I guess, in that way. So
right.
They're a pretty amazing, resilient bunch, our siblings. That's for sure.
Yeah.
Okay, let's see. The next question. My niece, 5, has worn out upper front teeth, incisors. So when will she get permanent teeth, considering all the global delays? Will they be the same or will they be better? She used to do a lot of teeth grinding, but fortunately it has stopped for now. Dr. Hale?
There's no... Dental eruption is somewhat related to bone age. But that being said, there's no reason to think that when permanent teeth, that there should be any problem when permanent teeth come in, other than the fact that they're going to be subject to all the same things that happen with primary teeth in terms of teeth grinding and those sorts of things. Again, somebody that is accustomed to dealing with special needs children or a special needs dentist, they certainly have things that they can do to help with issues like that, both to be sure that the secondary teeth in particular are protected from bruxism and tooth grinding and those sorts of things. But always the value of going to a large academic children's hospital someplace is because they're going to know, or ask the primary care pediatrician, know which dentist do all of your special needs kids go to, because that's the person that's going to know what works.
Can I add something, ask a follow-up question? We're dealing with this with my son right now, actually. I mean, he didn't get teeth till he was 18 months old. Then he had some orthodontia work, and we had to pull about 6 teeth. He wasn't losing his baby teeth. So last year they pulled about 6 teeth, or a year and a half ago, and we just went back. They're still not coming in. And they looked at it on the x-ray, and they're like, we see the teeth there. And I was like, well, everything seems so slow with him. So who knows? But, we've been going to our local orthodontist. I mean, would you think in that scenario there's a reason to go see somebody else? Or just
I would think about if you already have connections with a large academic medical center, I would ask they probably have a special needs kids clinic. We have a critical care clinic here, or some such name, but that often they know who the most knowledgeable resources are in the community or in the academic medical center. Most of the academic medical centers are associated with an academic dental school. So,
and were those top teeth or bottom teeth?
They're on the top. Yeah,
this is just my sort of observation, not knowing anything really about dentistry. So many of the people with 18q deletions have a really small midface. It's small this way, so it's kind of retracted, and it's small this way. And so the roots of those teeth can be really, really short, or that may be why maybe his teeth aren't even developing there. I don't know. But that tends to be more, teeth on the top tend to be more problematic than on the bottom with people with 18q.
All right, that's good to know. Thank
Not
you.
That helps, but it explains it maybe a little bit.
Yeah, no, I think I hadn't even considered going to somebody else. I just, assumed that, they knew what they were doing. So I think they do, but I think it might be worth just talking with someone else just to make sure there's nothing else we should be doing. Thank you.
So. Okay, next question, also for Dr. Hale. Does a potential growth hormone deficiency have impact on the degree of muscle hypotonia? If yes, will growth hormone substitution improve hypotonia?
Well, that's the $8 million question. So we have innumerable anecdotal reports specific to the chromosome 18 kids that when they get started on growth hormone, muscle tone improves, and that they often tend to acquire large motor skills. Has that ever been rigorously studied? No. So on the other hand, it's one of those questions that I always say, if there's some reason to start the child on growth hormone, that's certainly one of the things that's worth sort of observing. The biggest problem has historically been that the evaluation of muscle tone in an objective fashion that would lend itself to sort of scientific research usually requires the participation of the individual on whom you're trying to measure their muscle tone. And that's a little tricky with a 3-year-old or with a 12-year-old that can't really follow commands.
Okay. The next question is another question. I have a question for Dr. Hale about monitoring vitamin D levels. Mm-hmm. It differs across countries. In the U.S., as long as the vitamin D as measured does not exceed the dangerous threshold, if ever monitored after starting on the vitamin, The same dosage will continue no matter how large. In other countries, they decrease the dosage. Do you have a comfortable opinion about safe vitamin D supplements for bone density and overall health?
Well, I mean, the standard recommendations in the U.S. are between 30 and 100, and the great majority of people that write prescriptions for vitamin D, particularly if they're above the recommended daily allowance of 400 international units. So the kids that are on 1,000 units, 2,000 units, 10,000 units, almost everybody that I'm aware of will monitor that and make adjustments to keep the vitamin D level in the range of 30 to 100. So I don't know people that just keep them on it forever. If they're on recommended daily allowance, which is 400 IU, the likelihood of them becoming developing hypervitaminosis D is pretty close to zero.
Okay. Okay, next question for Dr. Larson. I think that was my question from yesterday about phobias and fears. Wondering if I can email you after this so I can get Lillian some specific help. Is that a possibility?
Mm-hmm. Yeah. Yeah, you can probably through Annis at the Research Center probably would be the best. She can forward any questions to me.
Okay. Let's see. Next question. They just use CRISPR therapy so far for the single gene mutation when death is imminent without it. Oh yeah. I mean, this is, yeah, a lot, not experimental, but sort of new types of therapies always get approval for things that are degenerative or really severe or when death is imminent. And so since that's not the case with any of our kids, there are kinds of therapies and the general techniques and technologies of gene therapy, et cetera. We would never get approval to even do a study about it until it's considered a standard therapy, because we're just trying to improve life or function as opposed to preventing death. So we can't quite be on the leading edge of that for that reason. That makes it difficult.
And compassion, I mean, there are compassionate use, but as you said, compassionate use protocols have to get through the pharmaceutical company, have to usually get through the Food and Drug Administration, and usually by all sorts of institutional review and institutional ethics boards. And just short of it being death, there aren't many options to move that ahead.
Yeah, and like the oligonucleotide, the ASO therapies, that's first used in deadly conditions. That kids who were going to die in a few years without it, and so the threshold for approval is very, very, very different. So doesn't mean we're not keeping track of all that, so that when the day comes or the opportunity that it makes sense in our population, we'll be ready to go for it. But it's not imminent for us. Next question says, for Dr. Cody, what's the impact of the missing non-coding regions of chromosome 18 on clinical conditions? The answer is, I don't know and nobody knows. It's something I'm tracking. There really only are a few, maybe like 15 non-coding RNAs on chromosome 18. I keep track of those and what's known about those, and it's pretty much next to nothing. And what I focus on is what would the effect of too many copies or too few copies of those be? I think only 2 of them have any clinical information at all. And as far as the other non-coding, the enhancers and promoters and all those sort of things, I also kind of keep track of that. If you have a deletion of the gene, it kind of doesn't really matter if you're not missing the enhancer or promoter regions. It's still not going to work. But if you're only missing the promoter or enhancer regions, that could impact it. And so when those are identified, which is, we're just in the infancy of being able to identify those. I mean, that's the kind of thing I keep track of in the literature daily. I get Monday through Thursday, I get all the newest publications in PubMed on 1/4 of the genes on chromosome 18 and actually all the microRNAs. So anything that mentions any chromosome 18 gene, I'm aware of within a week. And so I skim those for any relevance. Mostly they have zero relevance for chromosome 18 conditions. But I look at them all every week anyway to keep track of that. So when those things are known, that we'll be aware of that. The other thing that's not really in your question, but is also of interest, is we think of the chromosome as this long, and genes on the chromosome as this long linear thing, but it's not. It has a very, very defined structure where the DNA is wrapped around proteins, and then they're in loops, and the loops are in even bigger loops, and that's very, very controlled. And those big loops of chromatin impact the expression and use of those genes. So a disruption of that ability to have this big 3D structure form of the chromosome could impact the gene expression for genes that physically look far away when you look at it linearly. So I try to keep track of that literature as well to see if there's some long range kind of effects of a missing region here really means that all these other genes way upstream are affected that aren't missing. So that's a possibility. So sort of we're always trying to keep every possible angle in our minds that could affect someone with a chromosome 18 abnormality. So far, I don't know of any non-coding regions, microRNAs, or 3D structural TADs. What are those? I forgot what TAD stands for, but anyway, with the TAD disruption could, if it could have a clinical effect. But thanks for asking. So lets me talk about all the other things that I do and nobody ever asks about. Let's see. Next question. Let's see. Oh, I have one over here for Dr. Larson. Is there any info regarding autism and 18p minus that I could share with our psychologist?
Oh, wow, Mom, you might be able to answer that better than me. I haven't looked at that data in a while. It's definitely more common in 18p minus. We do know that. I remember a while back we were trying to figure out, is there a typical presentation or unique presentation of autism and 18p minus, and I don't think we really found any specific patterns of how 18p minus autism looked unique compared to, because autism, it's a spectrum. There's a very wide variety of ways that it can present in different people. But we do know that it's more common. I couldn't tell you the numbers. Do you know the numbers?
Not off the top of my head, but it's a pretty high number.
Yeah,
most of them are somewhere on the spectrum. Many on the very mild end. Mm-hmm. But
and which is true for most of the different syndromes, Q minus and but I can't remember the data off the top of my head.
Yeah, and the other thing is, why do you want to know? So some people don't want to get a label on their child. And so they really kind of want to avoid that sort of thing. I get that. That makes sense. The other side also makes sense is if you have the label of autism, you can access extra services sometimes. And for example, if anybody was just on the self-advocate panel, I guess I can say this because they said it themselves, both Catherine and Martin, very high-functioning individuals with 18q deletions, married, living independently, both had diagnoses of autism or being on the autism spectrum as adults. How old are they? Late 30s? I think early 40s when they got those diagnoses. but that enabled them to access extra funding from the government for support. Kind of explains why employment is a little more difficult, and it may help them access other services. So in a case like that, it can work for you. So you've got to weigh all the pros and cons. So you almost have to know why the person is asking the question in order to answer the question. So,
yeah. And generally with autism, the earlier you can start interventions, the better their long-term outcomes are going to be. And so if this is somebody who has a really young child with 18P minus, and, it's great to be aware of that. And if they're seeing a psychologist for, another reason, to be something that they should monitor for, and then get those services, start the ABA, start whatever therapy they need to be doing as soon as possible. Because there are lots of resources that, open up for you when you do have a diagnosis of autism.
Well, and the school systems understand the word autism. They don't understand 18Q or 18P or tetrasomy or whatever. Yeah. And what you want access to is services that are appropriate for the child. So I think that having the on balance, I think having the diagnosis, having that label probably is more beneficial to the child than not having it.
Yeah, it gives the school kind of a framework. They sort of have some idea, okay, kids with autism, they typically struggle with this and that, and they need help here, and they can kind of set up their, IEP or their special ed to accommodate a lot of those needs. Yeah.
It's interesting. We've had my son evaluated a couple of times, and they can never quite give him the diagnosis. And there are certain services that we can't access without that diagnosis. They're not some of the bigger services, but there are some programs around like peer social interactions and things like that. And they're like, unless you have an autism diagnosis, we can't have you participate because of the rules of their funding or whatever. So I've tried, we can't get it, but if you do have it, that can be helpful, like people said, for getting resources.
Okay, next question here. It says, Dr. Cody, is there a pediatric endocrinologist you can recommend in San Antonio who is experienced with chromosome 18P minus? We are considering moving to San Antonio to find a care team who have relevant experience, as our current team has little or no experience. You can talk to Annis about all the people you need to see. Dr. Eskanami, I think, is the one who's seeing all our chromosome 18 kids when they're clinically, not for the research, because we're not doing research studies that are clinical studies, but she's the member of the endocrinology division here that I think is seeing our kids.
And she can talk to me if she's got questions.
Yeah.
I trained her.
Yeah, he trained her. So and she's wonderful. Speaks Spanish as well, fluent in Spanish. So that's always a plus. The next question: are fractures in the same bones where DEXA said they were normal? Okay. I'm not.
Well, certainly normal, healthy children have fractures, but usually they are explained by adventurous activities or falls or drops, and it's quite different if a fracture has been induced by obvious trauma as opposed to a child who is bedridden who has had no obvious trauma and is having fractures. So you certainly can have fractures of normal bone.
True. Okay, so skimming down here, let's see, Dr. Hale, we have been trying to get our 18Q minus daughter on growth hormone, but her endocrinologist won't get it approved without a newish study proving it to be beneficial. How do we get a hold of this? We tried mailing like advised last year in the video conference. Thank you. I don't know. Let me tell you, the problem with the study, the reason there isn't a newish study is that how are we going to do it? as soon as all the families learned that growth hormone had a benefit, they all went to their local endocrinologist and got their kids on growth hormone. Even when we had money to bring them in quickly, they got it on growth hormone faster than we could get them in for a pre-treatment evaluation. So we can't do the study because everybody just who was eligible got on growth hormone faster than we could get them in when we had the funding. So I'm sorry. That's how it worked. So.
Well, and again, I'm happy to speak to the endocrinologist to sort of say. I mean, the cold hard reality is, as many people on this phone surely know, we have tried innumerable times to get additional clinical trials going with growth hormone. And for years, the growth hormone companies were more than willing to give us growth hormone, but they weren't willing to fund the study. And the NIH sort of said,
yeah, boring.
They didn't think it was an important question. So,
yeah. So it's been a challenge. But yeah, I mean, I think the way most people have convinced a pediatric endocrinologist is they have their endocrinologist give Dr. Hale a call. I think that worked in most cases. Natalia says why they want a newish study. I think they just probably want a bigger study or a follow-up study. But as I said,
we'd love to do it.
We've applied for that a few times and not been able to get funding for it.
You might, if you next time you speak to me, said we would love to do it. If they'd like to fund it, we'd be happy to accept their funding. Not the patient, but the provider who's making this kind of comment.
Yeah. Dr. Hale, do you age out of growth hormone?
Well, that's a good question. So certainly, I cannot answer that question specifically to all the chromosome 18 conditions. What I can say is that classically, growth hormone is discontinued in typical children is discontinued once the children's bones are mature, which for girls is typically around the age of 15, boys around the age of 17. There is certainly some adults, about a third of adults who were growth hormone deficient as children, clearly demonstrate ongoing benefits from growth hormone, although the dose is much lower when it's used in adults, when it's largely up to support maintenance functions as opposed to actual growth. We certainly have some data on 18q that growth hormone treatment using adult doses in individuals who had childhood onset growth hormone deficiency does seem to have some benefit in terms of body composition and maintenance of weight, or prevention of excessive weight, I guess is the correct way to say that.
Okay. Let's see, Dr. Manganello, as a parent of a chromosome 18 child, what's the one thing you would have done differently given the chance?
I think that's such a tough question because there's so many things you could do differently, and they could turn out worse than what you did. So, but I guess there's kind of a twofold thing. One is which wouldn't apply to anyone here, but I would have gotten the genetic testing done sooner because I did spend a few years going to different specialists and everyone was trying to guess what was going on. And I talk about that story in my talk, actually. And so I think if I had done that sooner, it would have helped. The other thing that might help people is I would have started asking questions much sooner about what services and supports were available to families who have children with disabilities. So I live in New York State. We're very lucky. There's some excellent resources. We have a waiver program. There's no wait list for our waiver. But for instance, I didn't even know, even though my son was born with different issues, no one ever said you should get in touch with our early intervention program. And it just happened that a friend of mine was a speech therapist in early intervention. And I was talking to her and she said, well, you should get your son evaluated, which I did. And then he qualified at that time for physical therapy. And I was super lucky to get a physical therapist who then said, why haven't you had him evaluated for speech and all these other things? I said, well, no one told me to. So she helped get that done. And then we got a lot of different services through early intervention. So I was really lucky to find a few people that helped guide me. And then actually, you'll find this interesting. I didn't know about our disability support services through OPWDD in New York State until I happened to see a mom in the 18Q deletion Facebook group comment about some funding, like a budget she got to pay for things in New York. And I was like, what is she talking about? So I looked into it and was like, so I didn't even find out about that till he was like 10 or 11. And so I would have started asking questions much sooner about what kinds of supports are available. And no matter how old your children are now, it's still a good question to ask, because there's always changes in what's available. And there may be resources out there that you don't know about. A lot of times it's the flip side where you hear about the resources, but you can't access them, or there's not the resources you need. But sometimes there are things and we just don't know until we ask or someone happens to tell us.
Yeah, our situation was sort of the same in that, Liz, born with a, severe cleft palate and cleft lip. We'd had multiple doctor appointments and she was a few months old, and I just called up the pediatric clinic and I said, I have this baby that's supposed to be, severely retarded and a vegetable, but I think she looks pretty good. But is there anybody that actually follows these kids? And I think the MA just, could hardly breathe for a second, and got us into see the developmental pediatrician who ran an early childhood program. And I mean, I had no idea any of that stuff existed. It was an entirely new world. So you don't know what you don't know. And so I wish people would have said something like that along with the day that we got the diagnosis. So here's some programs you can access or she should be involved in, and nobody did. So it's amazing to me.
Yeah. And I would just say, I would echo you, don't keep it to yourself. Don't feel like you're never get yourself in the thing you think you're the only person that's dealt with a special needs child. So if you see somebody else with a special needs child, walk up and say, hey, I'd like to chat sometime. Could we have coffee? Tell me what you know. Tell me what services your child has. And you find, just like the registry group does with the family meetings, we're always learning stuff from each other about stuff that works. And also recognize the fact that stuff that works in New York doesn't necessarily work in Texas. So you probably need to talk to somebody in Texas if you're in Texas.
Mm-hmm. Yeah.
And just to echo that, I would say, one of the resources, in addition to being in the 18Q group, is we had someone started a local group for families who have children with disabilities. And so it's any disability, but I get some of the best information from that group that's local and regional. So if you're not in a group like that, I've seen some for states, some for, regional areas and cities. I would definitely look for something like that, and see if you can connect with others, because a lot of times it doesn't matter if they don't have the same disabilities, they still know the services. So it can be helpful.
Well, and I think Marlene Brightwell in Australia did a ton of that stuff for people that weren't chromosome 18. She sort of seemed to be a valuable resource for an awful lot of people about services that were available.
Mm-hmm. Yeah. I'm going to skip one real quick that I can answer quickly about information about autism at 18P minus. I'm not sure if it says anywhere. So in the physician management guides, which you can get to, you want the PDF version because that's the whole thing. Just the face page is the part that's on the website, or is a web page. You got to go to the PDF. So go to the Chromosome 18 Clinical Research Center website and look at the patient management guide it says management and surveillance for 18P minus. And in there, I'm not sure if it says autism as such in some percent, but all the data from all the neuropsych tests are there. So you'll be able to see the SRS, which is social responsiveness scale, and all the data from the kids with 18P deletions at different ages, and all the other neuropsych tests that we've done. So any psychologist can look at that and then help you determine if that's sufficient to qualify, even if it doesn't have the label there, but all the data is there. So, okay, going back to regarding hearing loss, is there experience that cochlear implants have more benefit than behind the ear devices in hearing threshold of about 70 dB? Unfortunately, Dr. Perry it didn't give a talk this year. We'll have him next year, but I think the answer just has to do with the type of hearing loss, whether it's conductive or neurosensory and how severe. And I don't know of any of our kids who have cochlear implants actually with 18Q. They either have behind the ear or Bajas. I don't know anyone with a cochlear implant. So
my son has moderate hearing loss, and it's been interesting because he has the behind the ear hearing aids, and they have talked to us about the Baja. They were waiting to recommend it till the magnetic version came out in the US, which it did recently. And it's interesting because, what they've said to us is, it could help a little bit with the hearing, but there's pros and cons to both kinds of devices. And so we haven't jumped to do the Baja. I've kind of talked with my son about it, and in a way I will leave it up to him because he knows it's available, and it's, he says he can hear fine without his hearing aids, which that's a whole other can of worms. But so the info I've gotten from my ear, nose, and throat doctor and audiologist is that the Baja might be able to help a little bit, but again, there's pros and cons to the way you hear the sound and the use of those devices, and depending on what other issues your child have, a Baja or the behind the ear aids may work better or not, depending on what other kinds of disabilities or behavioral issues they have. So I would say, just again, talking to your own doctor about the needs of your child would be good.
Okay, thank you. Let's see, for Dr. Hale, for a toddler with Tetrastoma 18P, what would you look for in determining if growth hormone treatment is recommended or appropriate? My son is 3.5 and didn't have feeding issues, so pediatrician has not noted physical growth, height, weight, etc. concerns, although developmental delay, hypotonia, etc. are certainly present.
It's the usual, have a high index of suspicion. Certainly if the child, again, without knowing growth rates and without knowing heights, it's hard to say. There is a tendency among pediatricians to say, well, if they're above the 5th percentile, they're just fine, but one actually has to look at growth rates. And I also think, given the relatively high prevalence of hormonal abnormalities in the 18Q children, the chromosome 18 children, probably worth asking for a visit with an endocrinologist. Most endocrinologists do things like measure children much more carefully than the GPs do, would be a good example, and have the tables to calculate rates of growth. And that's often a place to start.
Okay. Let's see, his comments about NIH maybe getting funding for rare diseases. Oh yeah, there's a whole office of rare diseases, which we have worked with for what, Daniel, 20 years? Program people at NIH get it. The problem is you can't get it past the study sections, which I think this whole new DARPA-like thing they're doing at NIH is a way to get around study sections, which to me is, why don't you just fix the study section process? But they didn't ask me. So we're very aware of that. We're involved with that. And, chromosome abnormalities are they're so different from other rare diseases, which was really the beginning of the research talk yesterday about how different they are. They're defined by the genotype, by the fact you have a chromosome change, not by the fact you all have heart disease or all have this or that, because they don't. It's a chromosome change. And it's like this whole world of a way of looking at this. People who don't normally think about it can't wrap their heads around it. And it's just fundamentally different. Let's see, I'm looking for more questions. Dr. Hale, I have a son, 4 years old with ring 18, including TCF4 deletion. He started growth hormone at 18 months. It has dramatically improved his muscle tone and growth. Yay! He's starting to walk and on growth charts thanks to growth hormone, but he is also cognitively close to 12 months, requiring full care. His increased size is now making it harder to care for him. How do you balance the benefits of growth with the caretaker ability to care for children with intellectual disability? And how do you know when to back off the growth hormone? Great question that we've had before.
So, again, I don't live in your house, and my general approach to children with developmental disabilities where there are concerns about growth, part of the discussion is that growth hormone is not life-sustaining, and therefore there's nothing fundamentally wrong with trying it for some period of time to see if you get benefits, and if the benefits outweigh the risk. There is certainly an argument to be made that a child that is 5'10" and weighs 200 pounds is much more difficult to care for if you're having to lift them, carry them, transport them, compared to a child that's 4 feet 4 inches tall and weighs 110 pounds. So I think one has to balance those things off. And the only way that ever happens is within the context of your family. It's great the child's doing better in terms of physical activity, but if he's becoming unmanageable, can you envision how much more unmanageable he's going to be if he's 3 times as large? And I think that's the challenge. You might also try off for some period of time and see if the gains disappear, or whether they basically were a one-off and you've gotten as good as you're going to get, and probably there is no advantage to continuing. But you don't know unless you ask the question. As I said, it's not life-sustaining. It's like you're withdrawing life support from your child or putting your child at risk.
Yeah, and maybe I was reading questions and you mentioned this, but the kind of the other part is that it's easier to move and work with physically moving around somebody with muscle tone who's sitting up, and who, as opposed to a bag of jelly, so yeah, hard question, and it's a family decision. So, and we are over our time by 4 minutes, and I do not want to move into the sibling panel time, because that's always my favorite part. So there's a couple questions we didn't get to. If you can send them to the office, and they'll send them on to whoever the question was for. Thank you, all three. This was a great time. I was a little worried about, oh my gosh, can we fill a whole hour? And we did. And I thought it was an interesting hour. And I really appreciate your input and your help. And I know all the families did too. So let's move on to the sibling panel, and we'll see you all later.
Thank you.
Bye, everyone.
Bye-bye.